Sorry, the first. Which is the first? This. I bring greetings from the Sia Gascot, our Italian Society of Arthroscopy and Sport Medicine, Knee Surgery, and in particular from the President, Giovanni Di Giacomo, and the future President, Giovanni Bonaspetti. Tomorrow we have here the past President, Enrico Gervasi. So I'm here to talk about meniscal root tears and posterior meniscal root repair, a very current topic in the field of knee surgery, and I'm happy to speak about this. I have no disclosure for this topic. So we know that meniscal root tears are defined as bony avulsion or complete radial tears within 9 millimeters of the meniscal attachment. This is the classification system by Laprade, 2015, based on the tear morphology of the lesion. You can see 5 types. The most frequent is the type 2, is 68% of the lesion. I'm falling in love with this slide by Laprade. I photographed it 4 years ago in Vail, in USA, because for me it's more simple, but it's more direct. For Professor Laprade, root tear is a silent epidemic, not as rare as once too, often missed on MRI before the surgery and missing during arthroscopy. This is a problem because this kind of tears can lead to rapid osteoarthritis, for the inability to meniscus to resist of stress, the meniscal extrusion, for the loss of articular cartilage. And then we know that also the spontaneous osteonecrosis of the knee many times can secondary of root tears. So see, this is an example of my patient with the posterior lateral meniscal root tears and this posterior medial meniscal root tears. What about epidemiology? We know that from 10 to 20% of all meniscal tears is root tears, and that the root tears of the medial meniscus are 21.5% of all the posterior horn medial meniscus tears. In particular, the root of medial meniscus are more degenerative, and in women, middle age, with varus alignment, BMI over 30, while the lateral is more acute after a twist, a sprain of the knee, and according to ACL rupture until 14%, so in the young people, in the athletes. So what are our goals in root tears? For me, first of all, looking for lesion, because many times the problem is we don't looking for lesion. And so during the arthroscopy or before with the MRI, it's important to know we looking for the root in the medial or in the lateral compartment. Medial in the root lesion is like the ramp lesion. If we know how to look for tears, we can find it. But if we don't know them, it's impossible to find them. So once recognize them, we must know to treat it in correct way. So like all the surgery, there is a learning curve. It's hard, it's large, but it's not impossible. So this is a famous and beautiful work of Professor Laprade that explains us the risk factor, varus alignment, BMI over 30, and the history of the symptom, the sudden onset posterior knee pain, popping sensation. The physical exam is extremely difficult because it's not typical, there is no typical sign, and in these tears, the MRI can help us. How? There are 3 different direct MRI signs for the diagnosis of meniscal root tears have been described. Radial linear defect in axial plane. Okay. The vertical linear defect, also truncation signs in the coronal plane, the last one, and the so-called ghost meniscus. This is famous in sagittal. Okay. Meniscal extrusion is also considered to be an indirect sign for a root tear, but more in the medial, because it's not so present in the lateral meniscus. So, another work important about the part that speak that root tear is equivalent to not having meniscus. And this means that absence of the meniscus increased risk of totally knee replacement by 132%. And what about the treatment? They said that you can choose for conservative treatment in elderly people, only patients that have a significant osteoarthritis with KL over 2, and you can do also a partial meniscectomy in patients that can't subject to surgery, or root repair in acute or chronic tears, and in active patients that no have a significant osteoarthritis con KL1 or 2. What about surgical technique? Transtibial pull-out is gold standard, but there is a little case in when you can use the all-inside procedure. This is my patient, 25 years old. Twist, you have a ramp lesion of the medial ACL rupture, and this lesion of the lateral meniscus. You can see a partial detachment of the root and the incomplete radial of the horn. Is a type 1 by Laprade. I have do all inside procedure, and this is a medial view by medial portal. Be careful because I use this device from the lateral, and so for the direction of the devices, be careful from the vessel because you is in a bad direction, but you can see the tension that I can do with these devices, good result before I do the ACL reconstruction. So, I don't know if Professor Imhoff is also with us, but I want to thank him for his work and his school from this is the technique that also we do, especially for the medial root repair, because we prepare the socket, the bone socket on the medial with this kind of procedure. In the lateral, many times we use the same device of the ACL reconstruction, because before to do the reconstruction of the pivot, we do with the same guide, you can say the same guide for the ACL, to do the tunnel with the wire, and then we drill the tibia and prepare the socket for the lateral repair. So this is a video of our technique for the posterior medial root repair. We find a lesion, we prepare the lesion in the bone socket with the rasp, and many times in the medial compartment, this is so tight, it's necessary to do reverse notchplasty or pike rasting and good synoviectomy for a good visualization of the root. And so we perform the tunnel, we take the stitch, and with a suture passing, we do the suture for the root. You can see now the device to take the root, and then from the tunnel we take the wire and we fix in this piece. We fix them on the tibial. This is the tension. We can decide the tension, and we check the medial meniscus. Otherwise, in the lateral, it's the same procedure, but we perform them in a good way because the lateral is more large, and so in these cases we have used this device, but we have two suture, one more posterior and more medial, and I take the wire and take on my tunnel that you have do before. And the second one, this more lateral and more anterior to have a better control of the root and for a better tension of the meniscal root. And so is the final check and the final take of the fire into the tunnel, and then we fix it. How we fix it is not normal. Many times, all the times with the bottom. If you have any problem with the bottom for the tension, we use reservoir interference screw like in the ligaments. We do always 2 different tunnels for the ACL one before for the repair the root and then for the ACL. This is our X-ray check. After every surgery we do have the X-ray check. This is one guys we have perform ACL reconstruction, out-in technique for the femurs, and then you can see the bottom in the tibia for the root repair. Also for the BTB reconstruction, we use the same technique. This is another guys. Our post-op protocol is too simple. No weight bearing for 6 weeks. Restricted range of motion between 0 to 90 degrees of flexion for 4 weeks. And especially for the athletes, no squat or deep leg press over 90 degrees for 4 months. Clinical outcome. The first work is Feutz and the school of Professor Imhoff. It's a systematic review of transtibial pull-out repair that show that there is a improved functional outcomes with this kind of repair, with a mean follow-up of 30 months, and in radiographs and the MRI, no osteoarthritis progression in over 80% of patients. In the other work, Choi shows us that the incidence of medial meniscal root tears is over 78% the knee that requiring a total knee arthroplasty before 60 years old. So root tears correlated with severity of osteoarthritis for varus deformity in the mechanical axial division and in the BMI. Work. A clinical outcome by a work of Laprade, and he showed us that in his work he have 3 failure on 45 knee, so only 6.75% required revision meniscal surgery. There is a significantly improved outcome for his technique with double transtibial tunnel repair for the best control and the bell integration in the bone. No different in outcome over and under 50 years old and in medial and lateral root repairs. Another study, an interesting review and meta-analysis in 2020 that show us that there is better performance in repair respect to the partial meniscectomy, in the LISM score, in the progression of KLL grade, and reoperation. There is no difference in technical score, but we have always a good result with the meniscal repair, root repair. The last one, 2022, another work that analyzed the EKDC technical VAS that show us that we have a better outcome for a root repair. My take-home message. Don't miss root tear, please. If you want to reconstruction ACL, PCL, cartilage treatment, you must also be ready to repair a root tears or a ramp lesion. Better outcome always in repair respect to conservative treatment or meniscectomy. Age doesn't matter, but cartilage status does. And follow always a proper rehab. We're waiting for you in Milan in April for the second annual meeting of the SIA Gascot, and I thank you very much for your attention.
Thank you, Dr. Bettinsoli.